Good. All right, so good afternoon, everyone. Welcome to noon conference today. So today, again, is a very special noon conference. We have our attending challenge with Dr. Osorio, or on Dr. Osorio. Dr. Osorio, I'm sorry, I've been looking forward to this one. All right, so just saying, I know it's going to be an easy case with you, but the questions, I'm going to try to make them a little bit harder. So we'll see.
Okay.
But I know this is going to be perfectly fine. So for you guys, let me say this. I want to do a series of 2 attending challenges with Dr. Osorio. And this is going to be the first one. This one is not very complicated case, but the questions that Dr. Osorio is going to be answering for us today are very important. And then we're going to do a second one with a more complicated case. Is that okay with you? We got the commitment already. That's good. So we should start. The case, this is Mr. X. He's a 32 years old male who's coming to his primary care doctor for a regular checkup. He's concerned that he may be at risk for acquiring sexually transmitted infections because he has been having unprotected sex with multiple partners. His partners are both males and females. He's particularly concerned about the possibility of being infected with HIV. So my first question is, as a primary care doctor, what would you advise this patient to prevent HIV infection? So prevention.
Prevention first, okay. I'll stay focused with the questions. I was going to go off just on what you told me. So focusing on prevention. So many of you guys know, so I also do the PEP hotline. So this is something that we get asked all the time. And the concern is always, so prevention of HIV or STIs?
HIV.
So in terms of prevention of HIV, so basically one thing that I make a comment is, it's all about fluid to fluid contact. So fluid to fluid, majority of the time you're thinking about blood or just seminal fluid, and what type of contact you have. And it could be sexually, it could be injection where you're sharing needles. And that's basically what you're trying to do is you're thinking about, okay, where are my exposures and the risk is higher when you're thinking about fluid to fluid contact. Okay, so then what can I do to prevent that? So then you think about barriers, and barriers is going to be depending on what exposure you're thinking about. So if you're thinking about exposures to IDU, then of course you're not going to be sharing needles, or you're trying to do as much as you can in terms of getting clean needles. If you're thinking about sexual, then you're going to use barrier protection, which is condoms is what you think about. Condoms being not just for what you consider vaginal and anal sex, but also for oral sex, which is the most common thing that you hear about, is that I don't like to use condoms when I am performing or receiving oral sex. And so I think first you have to think about the exposures that they're talking about, and then you have to think about what type of what they can do. And in sexual exposure, you're going to have to think about barriers, and that's going to be the condoms is what you're thinking about. So that's what I would say, number one.
Perfect. So I want to just, in the same context of prevention, I want to focus a little bit on PrEP. Since it's something that is more and more a thing of the primary care doctor, I think all of us should be aware of all of these things and how to work there, the medications and what medications to work. So my question is, what are indications for prescribing the exposure prophylaxis? What drugs can be used? And what should be done before starting someone on PrEP? And what should we be doing after we started someone on the exposure prophylaxis?
Okay, this could be a whole talk in itself is all I'm going to tell you, but I'll keep it as a short answer. But so PrEP is different than what you hear about, which is PrEP. So PrEP is pre-exposure prophylaxis, and PEP is the post-exposure prophylaxis. So the PEP is what you think of, most people know about because of occupational PEP availability that we have here, but PrEP. So PrEP is pre-exposure prophylaxis. So it's been nice to be in training where this was actually being implemented. So when I finished residency is when the first article came out, really in 2010, and that was by Grant et al. And during that period of time, in the last 9 years, you've just seen a lot of dissemination and implementation of PrEP. And what's nice for me is when I first started here, I remember teaching you guys about PrEP. And now and I used to think, okay, as an ID attending, I really shouldn't be the one talking about PrEP. It should be the internist, because you're the ones that are seeing the people that need PrEP, because the next question is who's going to need PrEP. And now what's been nice is that, yeah, the residents are teaching each other, and Heather, Dr. Viola is one of the first people that gave the senior lecture on PrEP. And I was so impressed by her lecture, just because I was like, yes, the tide has changed, and the internist is teaching the internist PrEP. So PrEP is pre-exposure prophylaxis. Who needs it? Well, PrEP is, what it is basically what we know now, and I'm gonna talk about TDF and TAF, but for now we're gonna use Truvada. So Truvada is TDF and FTC. So TDF is tenofovir diproxil, and FTC is emcitribine. So this is, and why it's being used, so going back, so this is one of your NRTIs. It's a combination pill. The reason why it was selected first to even be used in the original studies for PrEP is really because of its half-life. It has a long half-life, and also it concentrates very well in the rectal tissue. So all that allowed it to be a very good drug to think about in terms of prevention of HIV. The other thing, it's once a day pill, and now we can talk about later things regarding that, but it's once a day. And so all that makes it a nice drug to think about, can we use this for pre-exposure prophylaxis? And so now for sure, we know with multiple studies that yes, you can use it for pre-exposure prophylaxis. Who should you give it to? Well, it's the people that you think are at risk for HIV. I just talked to you about different people that you might think are in different communities that might be considered to be risk at HIV. One of the first people that it was approved for was for men who have sex with other men. And the reason that is because for anal sex, it's definitely, because it has high penetration in the rectal tissue, it's definitely something that can be used. Another thing that it's been approved for is for, I would say, men or women who have sex with their discordant, so either women or men. I would say women here, going back here, any women, anybody who has any type of anal sex, so women or men, receptive, are people that you should think about. And then IDU, it's not to forget people who are injecting drugs. So all these people are people that you should consider to be at risk for PrEP, are the ones that you should think about considering giving them the conversation about HIV, using PrEP. And in reality, any of this, I would say anybody who's thinking about, or anyone who is sexually active, you really should be having the conversation with, is what I would say. So number one is, who should you be talking to, is everybody. And then these are the communities that you're thinking about could be at risk. And then, just because, again, this could be a whole talk, is what do you do when you're talking to someone? You bring up the topic, you ask if they know about it. A lot of times people don't even know what PrEP or PEP is. You explain to them what PrEP and PEP is and what they're used for. PEP, going back to PEP, you can only use it, it's only really good if you're within 72 hours of exposure. And that's gonna be FTC, TDF plus dolutegravir in men and women who are at childbearing age. Then you want to use the Centris, because unfortunately dolutegravir has been known to maybe cause neural tube defects. So that's PEP. And for PrEP, so here's your conversation. You have your person coming in. You have someone that may be saying, I have had no exposures, nothing, even oral, unprotected oral sex, nothing for more than 72 hours, nothing for a week. And I really want to talk about PrEP. What can I do to get started on PrEP? You give them that this is, it's FTC, TDF. TDF, is concerns for renal function. So what you're gonna do is you're gonna get their history, any exposures that they have. Have you had any exposures? No. You send for HIV testing. What type of HIV test? Does anybody know? Because I really don't want to be the one talking.
We'll ask you about that.
Oh, okay. So we'll leave that for now. So you'll send HIV testing and then some routine testing, you don't necessarily have to do a CBC, but at least a Chem7, because you're looking for the creatinine clearance. And there's something else that you should be checking, two other things. Yes, so hepatitis B, because the thing about it, TDF, is you have some activity against hepatitis B. And then the other thing that you should be looking for is concurrent STIs. So concurrent STIs is RPR, all other hepatitis panels. And then you want to do your GC screening. And GC screening is not just your usual urine that you think about. You're doing all sites that any person could have exposure to sex. So it could be oral, which is a throat, GC, or a rectal. And these are what's called aptima cultures, and they're just swabs. And so you do all site testing. And what I always tell my patients, because they're like, oh no, I don't have any symptoms whatsoever. I used to work as a fellow at an STD clinic, and this is where I learned transgender medicine too, at a free clinic in San Diego. And we used to do 3 site testing, and these were people that were just coming in. Yes, some of them reported 100 partners, some of them were starting a new relationship, but they were all asymptomatic, and we would do 3 site testing. And I always ask, which one of the 3 do you think came back positive, the urine, oral, or rectal? What do y'all think? What is it? You're saying oral. Anybody else? Oral? Okay. So yes, it was the oral. Asymptomatic, nothing. No sore throat, no drainage. The most common thing that came back positive was the oral. And to this day, we do 3 site testing in our clinic. This is the one that comes back mostly positive. And then the rectal in our clinic, and I know at the Ryans they're doing this too, the patients do it themselves. So they self-collect this. And it's actually been really nice because once they do the urine, they just do the self-collection for the rectal. And so the oral is the one that comes back positive. So once you do all this basic testing, then you basically are able to give 90-day supply depending on what test you're going to do, which we'll talk about later. If it comes back negative, then you're allowed to give them a 90-day supply and just have them follow up every 90 days. To me, it's all about the education. It's all about the counseling. And the other thing that you guys hear me say a lot, it's about giving access. This is all about the comfort for us, but it's also allowing the person to have access to be able to get this. And if y'all seen the media, just today, I got an alert from the HIV that the federal government is basically going to provide PrEP for free for many people. And this is something that's going to be disseminated throughout the country, and something that as internists, a lot of us are going to be put in a place to be able to provide this to our patient. So I stopped there just because.
Just like for me, so once the prescription is sent, what do you do for follow-up with this patient?
So when you send a prescription, it's usually routine, like 3 month follow-up is what I do. Every person is different. Some people follow up in 1 month after initiation. I think some people even follow up a week after initiation. I mean, I always just, if they're new, I'll email them or they'll call me and we just talk about side effects and make sure that they're okay. Side effects, most common is nausea, but it's because if you're not used to medicine, your body's going to react this way, but it's the most common side effect that you have. But within a week, when the person is taking it with food and they're doing okay, it usually resolves on its own. So usually the follow-up, depending on the person, but for us, I do 3 month follow-up after initial start. And I'll tell you once the test comes back negative, because I give the prescription, I confirm, what I do is I confirm the pharmacy that we're going to send it to. And I tell them, okay, I'm going to call you as soon as our testing back is negative, and it confirms that you're negative. As soon as it's negative, which is within 3 days, I will go ahead and send a prescription. And you already have your pharmacy on file, so I'll just send it over. Some people are different. They'll just go ahead and give the prescription. I want to confirm that you're negative before I'll give you the prescription. So, it's easy now with e-prescribing. I mean, most of the states do e-prescribing now, so it's not a barrier for them to have to come back to get the prescription when the viral load or whatever that you did comes back negative. So you just, confirm, you make sure that they're negative. You're calling them, making sure you're releasing these records, but you call them, let them know that they're a go, and then they can get the prescription. They can start right away. Now, the only thing that you have to make sure, and this is what's really hard, is you really cannot have any exposures during that period of time, because now you set yourself up, am I going to be concerned? And so it's really an honor code to let the person know, look, like I did this testing, I did it by what you told me, it came back negative, now I'm going to give you this 2-drug regimen, which is Truvada. And if you seroconverted in this period of time, the problem is it's not 3 drugs, it's 2 drugs. And if you're HIV positive, you know that we need, you know, yes, we can talk about that later, but majority of times you need 3 drugs to be able to treat HIV. And also if you had some underlying, if you ended up getting transmitted resistant virus, then Truvada may not be enough to treat the HIV. It never will be. So I don't want you to seroconvert. So you really are in an honor code that you are not going to have any exposures in that period of time that I'm calling you with a negative result.
So how often do you test these patients for HIV again after they started on PrEP?
Every 3 months on the follow-up. So every 3 months on the follow-up, you're gonna test for HIV and your basic Kim7, and then you're doing your STI testing. And this is every 3 months. And you just, I also like to give them any updates on, because a lot of people who are on PrEP, they're also very well versed on what's going on. And so they're always asking, is there anything new that's coming on? Well, new in the horizon, which I kind of was telling my patients on PrEP since the very beginning, is the fact that the TAF formulation, which is Descovy, is now approved to use for PrEP. So this just came out in November, so the 19th. So now this is actually can be used. And so patients were very aware, some of the patients, not many, but the majority of patients were aware that unfortunately this TDF component can lead to renal issues and bone issues, and we can talk about that later. But and they were always wondering, when is TAF going to be available for PrEP? Well, now it is available, and what I've been told from on the ground, it's not really been any issues from the insurance perspective to get it for our patients, and that some people have seamlessly been able to move from Truvada to Descovy right away. So this is another drug that can be used for PrEP. So not just Truvada now, but actually Descovy. And you want to check them every 3 months and basically get HIV testing, Kim7, and then your STI check. And how long, it's up to the patient. I think a lot of what we do is patient-centered. You know, the question now is always like, you know, how long should the patient be on it? When should they stop? When can they stop? I think it's always going to be case by case, and you have to talk to your patient. I would tell you that, yes, in the PEP hotline, I do get people that, you know, they were on PrEP and they stopped it 6 months ago because they thought they weren't at risk anymore, and now they're calling for PEP. And I think it's just going to be one of those things that we are always going to be kind of on top of. You know, again, just one more thing on PrEP. So now one thing that you guys have heard about is the 211. So this is the Ibergay. And I think so it's the Ibergay study. So this is the on-demand. So some people are now talking about, okay, who should be on daily PrEP, who can be on on-demand. One thing I would tell you, your women who are only reporting vaginal sex, they're only going to be able to be on daily PrEP, because any of these formulations, TAF or TDF, they don't penetrate the cervix that well. And it takes up to, some people quote 20 days of steady state, like 20 days of being able to take the medicine before they can honestly say that the person is completely protected from HIV acquisition. Versus for anal sex, if they're talking about just having anal sex, which again could be a female, or especially for your transgender female or men, then anal sex, the rectal tissue, that's been given like 5-7 days, and that's with 1 dose. So 1 dose of FTC TDF can give you a good steady state within 5 to 7 days. And so that is why for anal sex, now the question is, can you really do on demand? Do you really need to do daily PrEP? And on demand is the 2 + 1 + 1. Does anybody know what I'm talking about? What is 2 + 1 + 1? Very good. So 2 pills, 2 to 24 hours before exposure. And exposure, we're talking about basically sex. I think it could even be others, but I'm just going to focus on this. 1 pill 24 hours after. 1 pill 48 hours after. Controversy is, okay, let's see, you continue then you continue, and your last dose should be 48 hours after your last exposure. So the main thing is just remember this. So maybe what's going to happen is everyone going to be on daily? I don't know. Is everyone going to be consistently taking PrEP every day? It could be that we could have a subset of people that are just going to be doing a 2+1+1. And the New York State or the New York City DOH has already said this is good, but good really only for this and not for women. So that's why I think you have to be very clear about who can use on demand and who can use it, who cannot, has to be really on daily. And daily is still going to be women. And it has to do with the fact that the medicine doesn't penetrate the cervical tissue as well as it does for the rectal tissue. And then you have to worry about steady state and whether steady state develop, and steady state is going to take longer for it to be really concentrating itself into the cervical tissue versus the rectal tissue. And that's why when you hear 2+1+1, really it should be only for people who are exposures are anal sex, basically. Right. And that'll be it for PrEP for now.
So I think we have a very, very, very good sense of what is important for HIV prevention, particularly PrEP on that. So let's continue with our patient. So patient Mr. X, PCP introduced him further and discovered that he had unprotected sex with a new partner who is HIV positive about a week ago. So he's now, the patient is asymptomatic. So next question is, how should we proceed in terms of diagnostic testing for HIV in this case? What diagnostic tests are available? And I would like to talk a little bit about the performance in terms of sensitivity, specificity, negative predictive value, positive predictive value of this test.
And how long ago was it?
1 week before.
Okay. Okay. So as you know, this is what I did as a fellow. So this is the key word. It's 1 week ago. Do we know anything about the partner? Are they on medications or?
We don't know.
Okay.
So
we don't know. So we don't know if they're on meds, and we don't know if they're undetectable. But regardless, like the main thing that we have to figure out is what to order, because this was a week ago. And so times have changed in terms of, we're testing. We're no longer doing Western blots. That's one thing to understand. And what we send off for now is the 4th generation test, which is testing for P24 antigen and one P24 antigen, 1 and 2 antibody. And what this 4th generation does is it's trying to get you into the early stages of HIV. It's trying to diagnose people early. And we're trying to diagnose people early for different reasons, but the main thing is we're trying to capture them at an early period of time where they could be transmitting, because their viral load might be very high, because as people may know, when you're early or acutely infected, this is your time of exposure, your viral load could skyrocket from the very beginning. And this time when your viral load is very high is when transmission is very high. And many years, and even now, you would say that about 25% of the new infections in the US were being caused by people that had been tested in the antibody time, and they were told they were negative, but in reality, they were acutely infected, and they were transmitting their viral load was very high, so they were transmitting the virus to others. And so what the P24 antigen does besides the antibody, so what I always show is this one, where you have your exposure, you have 7 days, which is what he has. You have 18 to 21 days, and you have, 4 to 6 weeks. Sometimes I give 8 weeks, but really it's 4 to 6 weeks now. So 18 to 21 days. So this is your exposure. Your window period for the P24 antigen and antibody test, antigen and antibody test, is 18 to 21 days is the window period. And what a window period is this is the time when you have been exposed, but you may not have developed either the antigen or the antibody at that time. Your viral load is very high, but your own innate immunity, your own innate immune system hasn't responded yet to the infection. So if I were to do a P24 antigen antibody test during this window period, this test will come back falsely negative. And what you're trying to do when you get the story, the history, is you're trying to prevent as many false negatives as you can in your testing. You're trying to be as reliable as you can with your testing. So he gave you 7 days as being the time that he was exposed. So you can say that at this time, this may come back negative. And you're not going to be relying on just this test to say that this person was not infected at this time. And better yet, just because I'm going to put the prevention, this is too long for you to be able to even talk about prep for him, right? Because it's been a week. And so it's not the 24, 72 hours. So now the P24 antigen antibody is going to come back most likely falsely negative. So now what do you do in this period? So the nice thing is, so Dr. Little, there's so many people that are known for this, but Susan Little was one of my mentors at UCSD. So she's known for acute early HIV. And she did a lot of studies looking at her cohort. And what she found is that your viral load, if you were acutely infected, could also come back falsely negative at 7 days. So you really are not going to be relying on doing a viral load unless it's beyond 7 days. Some people say even beyond 10 days. But beyond 7 days, you can do a viral load. And then you come back, and depending on the exposure, and it may come back positive or may come back negative. If you're really concerned, then you may have to work with this window period a little bit. But the viral load is what I would send here. I would also just want to make sure he wasn't infected before. So I would send a P24 antigen antibody because maybe he had other exposures and he's not been tested. So what I asked is not when was your last exposure, but when was your last HIV test? And that's going to give me a little bit of idea of like what's happened, and then what other exposures he's had before is the other things that I asked. But I would send for a viral load, and I would send for a P24 antigen antibody test at this time, is what I would do. Then your antibody is over here. So your antibody is at 4 weeks. So this antibody component is not going to be sometimes positive till 4 weeks later. So it's all about your window period and when you're concerned about the patient being exposed and when they were infected. Once you send this off and you have confirmatory, then this is when you're going to send, of course, your CD4, and that's a different time section. Go ahead.
So Mr. X is tested for the 4th generation HIV test only. The PCP decided not to send the viral load. The results come back negative. His PCP advises him that he needs to come back in 2 weeks to be tested. Mr. X, he thought that because he had tested negative for HIV initially, he was okay. So he went out and about, and he didn't come back to his PCP. So 2 weeks and so after the initial visit, he has developed a fever, some malaise, some swollen lymph nodes, to the inguinal region, has generalized macular erythematous rash and a sore throat. He now goes to an urgent care center. So if you were the doctor in the urgent care center and you had the opportunity to see an epic note from the prior visit when they were discussing about possible exposure to HIV, what would you be concerned about at this point, and how would you proceed in terms of testing that?
So this is always a board question on ID and even sometimes medicine boards. So I mean, acute early HIV, and of course, like any other viral syndrome, EBV. One of the things that I find astounding when I was a fellow is even in the ED, if someone came in for STI testing, they wouldn't send for HIV testing. So it's just something just to be a note of. And a lot of people present this, and this is usually called viral syndrome on ICD-10. And they don't think about HIV either. So just always having HIV in your background. But for him, the two things that I would point on is this, just from his history, I would say that I have to send either the P24 antigen again, or just send the viral load at this point. But my suspicion would be so high that I would, in my situation, I would send a viral load and a CD4 because this would help me in terms of management. But I would be okay with also sending a P24 antigen antibody. And then EBV you can think about, and again, maybe send for some concurrent STIs if he has anything further, because you have to think about what our talk last week with regarding syphilis and being concurrent. When you diagnose HIV, think about your STIs, consistently syphilis, and the other way around.
So in terms of the acute HIV or acute retroviral syndrome, can you tell us a little bit about what common symptoms that patients exhibit when they have this?
So you have to think of it as being a viral syndrome. So a lot of people have tried to think of scores because, you know, people think about like a scoring system. When you have these different points, you should think about acute HIV. I think for me, it's really the history. You have to really get a good history, and I find that you also as a provider have to be very comfortable with asking sexual history. I think we don't ask sexual history a lot of times, and we just assume that the other person is going to bring it up with us if they had any risks, or they would have talked to us about it. I've had Dean, when I was last year doing my MPH a few years ago, not asking a 70-year-old for HIV testing, and she's the one that asked me if I could get HIV tested. So age does not matter, please. And just being very forthcoming with the sexual history and asking them, because I think the more you show the patient that you're comfortable with the questions, the more open they're going to be with you, and they're going to tell you things that you may not have known. And I find this with everyone. And so I think for me, it's the history and the sexual history that you really have to pinpoint. But the most common symptoms that you think about is what I said, a viral syndrome. So fever, lymph nodes, sore throat have been like the things that people have mentioned, and rash. But rash sometimes you don't see, especially if you are dark skinned. But the one that most people have seen is sore throat. When you look at, like, when I'm talking about, you know, studies that have been published, and when they start, you know, because especially my mentors always wondered, why in the ED, why in these places do people not test for HIV? Why are they thinking viral syndrome, but no one's testing for HIV? And of these people that were not tested, how many of these people had acute HIV? And of those who had acute HIV, what was the most presenting symptoms? And what we would look at and what was the most common symptoms is really just like fever or sore throat. And rarely was it rash, because sometimes the person didn't even notice that they had a rash. And like, and sometimes they would just have a STI, and they would blame the STI on these symptoms and not think that maybe they should test for HIV. So sore throat, rash, and the rash I'm talking about is the maculopapular rash, not itchy, can be diffuse everywhere. And then sore throat and very high fevers. I'm talking about like 101, not like 100 or 99. So again, going with like a viral syndrome. These scoring systems you'll read about, they really haven't taken off. And I think you just have to really focus on the sexual history and the history overall of the patient, and then think about some of these symptoms and think of it as a viral syndrome in some ways.
So the doctor in Jorgensen started, of course, actually, unfortunately, very uncomfortable. So by diagnosing this patient, so he decided to send the patient to the ER because he was concerned about antiretroviral syndrome. So in the ER, both the 4th generation HIV test and the viral load were sent. The 4th generation story came back positive, and the viral load came back with a viral load of 400,000 copies. So, question to you, if you were the physician seeing these patients, first of all, what would you do as a next step in terms of workup and management? And my next question is also, can you discharge this patient right away? And what if the patient doesn't have medical insurance? So how do you troubleshoot these issues?
A lot of questions there. So at least you got me laughing. Okay. So, you know, one thing to make clear with these 4th generations is we do blood draw here, but you have to understand that it's actually a finger stick. And in our clinic, we do a finger stick. So it's available within 20 minutes, the results. So we don't wait for a blood draw to be done. But in this situation, so you confirm, you know, so this is confirmed HIV, right? You hope that this is a face-to-face encounter and that you're actually talking to the patient. This is something that is very hard regardless of where you're at. I notice, you know, I train in Texas and California and New York City. I'm here, and yet it is one of the hardest things to tell a patient, in the sense that they're knowing just what society has told them. They also just have visions of, you know, the 1980s and what media has given them in terms of what is HIV and what is AIDS and what's the difference between each. And I think that this has to be a face-to-face encounter that you're having with the patient. And you have to let them know, and you focus on the positives in the very beginning when you first meet someone. But the problem is that you have to understand, when someone hears that they're HIV positive, their brain is already going somewhere else. Their brain is already thinking about what they've heard. or what they've seen. And depending on the age of the patient, some of them haven't even seen anybody. There's, when I was growing up, and I will age myself, it's fine. Ryan White was in the media, the 13-year-old individual that got HIV infected by blood transfusion that got banned from Indiana public school system because they didn't want to be around, parents didn't want to have their child exposed to an HIV positive individual. Magic Johnson, so many people, it was in the media is what I would say. And so I think the stigma is still there. And what, is seen in terms of what is AIDS. So one of the first things I ask someone, and this has been my tidbit as, as training, as I train, I figured out things that I can do to help the patient, is I ask them 2 questions. Do you know anyone who has HIV? Yes or no? So do you know someone who has the HIV? Yes or no? Do you know someone who has HIV who's on treatment? Yes or no? If they say yes to these 2 things, I know I'm talking to someone that knows something and maybe has an idea. Maybe their friend who is HIV positive, who's on meds, is like any one of us, looks like any one of us. And maybe their knowledge base and their psychosocial, like their mind might be thinking something different. Versus if someone doesn't know anybody who has HIV, and especially not anyone who is on treatment, their brain might be thinking more about what the media has told them. And so you already know that you're not going to be able to really talk to them about a lot of things. And my main focus, my first visit, is knowing where the person's at. And again, patient-centered, where is the patient at? And what questions do you have? That's all I ask in the beginning. Where are you at? And then I leave it open to see what they say. If they're completely blank and they can't ask any questions, then what I focus on is I tell them what's the difference between CD4 and viral load. And some people will say this is wrong, but I always say CD4 is your immune system, viral load is inflammation. And CD4, because sometimes you're not going to have the CD4 back, and all I have is the viral load in this patient situation. CD4 lets me know how strong your immune system is. If your CD4 number or percent is less than 200 or less than 15%, then I know you might be at risk for just infections that are around in the environment that we are all exposed to, but our immune system is not strong enough yet. Versus the viral load is your inflammation. So this is where I'm trying to help you preserve your lymph nodes, your nerves, not have these reservoirs saturated with viral load, and from the public health person, not prevent transmission or basically prevent transmission. And these 2 things is why I need to talk to you about starting HIV meds right away. When to start, from the very beginning, even before we, I know we're going to talk about this maybe later, is the test and treat. Before this paradigm of testing someone and treating right away, I was always like, when do we start HIV meds to the residents? And their answer would always be, when the patient is ready. You may have some patients ready and they want to start right away the first visit, and you figure out what to do then, and I'll talk about that in 1 second. Or you may have someone that's not ready and you want to make sure that they follow up right away, and we set up a way, and I try to meet them usually within a week or 2. You have someone that doesn't have insurance, you said. One of the reasons I'm here in New York City. But also I was there's some Ryan Wright Medical Prize Coalition, so I was the co-chair for that. So one of the nice things about the US is that we have something called Ryan Wright Funds. And this was named after the kid I just mentioned. His mom, after he passed away, his mom continued advocating and developed this program that's basically federal funds that the US gives to each state to provide basic care to patients who are HIV infected. Basic care meaning meds. So no patient who is HIV positive, regardless of status. I would tell you, because New York State is so, we have a lot of resources. The only patients that I have who are only Ryan Wright funds are patients that don't qualify for Medicaid, or basically who are undocumented. So they are able to get their HIV meds and their medical care and their dental care and their mental health care and they're guying, because Dr. Gantz was just here, they're guying all this through Ryan White funds. Medicaid's not paying for it, Medicare's not paying for it. All this is provided through federal funds that the state receives. So no, insurance is not a barrier for this patient to get started on HIV meds. In some states, it does take a while for the Ryan White insurance to kick in, because you have to apply and you have to show that, get confirmatory testing, things like that. In New York, it can be as quick as 48 hours. As soon as the patient gets confirmed and you get some documents from our social workers who are on the next door, some of them walking outside right now, that within 48 hours, you fax all this paperwork in, you get an ADAP number. And with this ADAP number, they can go with their prescription to a pharmacy and get the medications. Some clinics will actually have copays or meds through the pharmaceutical companies. I'm not going to mention that because we don't have that. But some community health centers here in New York City actually do have like a short supply of meds that they'll give, that the pharmaceutical company has given them. But we use the Ryan White funds to just try to get their ADAP activated. And this can be even for someone who's out of state who we're trying to work with, trying to get Medicare or Medicaid, or trying to get another insurance. So basically, insurance does not matter.
And then in terms of more comprehensive, of course, you sent us before, what else should we send at this stage? How the patients be diagnosed with?
So CD4 viral load, your CBC, your CMP, your lipid panel, your hepatitis panel, your quantiferon, because you're doing TB screening. I'm a internist first, so and also because some of the meds, I will send more A1C as well. This will be, I'm just trying to think, this will be my basic thing. I will not yet send, because other people say HOB57, this is for a bacavir. If it's positive, then you can't use this because of drug hypersensitivity, but I would not send that because it's not my first line. It's what you're thinking about, what you're going to start already. And so for me, it's just the C4 viral load,